All right, good afternoon. Today is April 16th, Friday. Well, I'm going to start calling these events Bariatric Friday. So today is uh, our second event with American Surgery Center and CHRIAS. My name is Kemal Erkan. I'm the chairman of American Surgery Center. And I have Dr. Isaias Irgau with me, our president for CHRIAS and our co-chair for United Medical ACO. Dr. Irgau.
Thank you, Kemal. Hello, everybody. I am Dr. Irgau. I am the president of the Christiana Institute of Advanced Surgery, as well as the medical director of bariatric program at the American Surgery Center. I have been doing bariatric surgery now for almost 20 years with my colleagues. I am actually have been very instrumental in starting the modern side of bariatric surgery in our state. I'm very proud to say that. And our group has been leading the efforts of establishing centers of excellence in all the areas, main health systems, and more recently, of course, at the American Surgery Center, where we have established a center of excellence for bariatric surgery, one of the very few in the entire country. So again, thank you, Kemal. I'm very happy to be here.
Thank you. So I would like to also introduce our other providers, other surgeons in the program. And okay, so everyone knows already Dr. Irgau, and that we have Dr. Gail Wynn, Dr. Michael Peters, Dr. Rahul Singh, Dr. George Ibrahim on the bariatric surgery side. And also we have Dr. Sachin Wade as a colorectal surgeon and our surgical PA, Sydney, who's with us. Now, many of you who are part of the program, you already know Amy, Fran, and Beth. They are our dietitians, nutritionists. They are specialized in bariatric, and they are part of our team. Today, we are going to discuss who is a bariatric surgery candidate for outpatient surgery centers. We are kind of highlighting this piece on the outpatient surgery centers. Now, from the beginning, bariatric surgery, most of the surgical types of bariatric surgery, surgery types of bariatric surgery is outpatient. Even if it's done in the hospital, it is always labeled as outpatient. However, we took this to a different level, and we are focusing our center at American Surgery Center and making a bigger impact in bariatric society, because we are one of a kind with the MBSA QIP accreditation, only 10 in the nation under the surgery centers, and with other certifications that we support this. So Dr. Irgau, I was gonna actually ask you, and then you would actually kind of educate us who is a candidate for the outpatient surgery center from the bariatric side. If you can actually just go over that with us.
Absolutely. So a broad answer to that, Kemal, would be that most people who are candidates for bariatric surgery are also candidates for outpatient bariatric surgery, the vast majority of people. Okay. Now, first of all, let's look on who is candidate for bariatric surgery. Bariatric surgery is a procedure that is undertaken as a form of treatment for morbid obesity. It's a weight reduction procedure, it's a metabolic procedure, and the goal is to reduce significantly the weight of the person, but also get their health at a much better place from the point of view of diabetes, high blood pressure, sleep apnea, and so forth. Clearly, somebody who needs to lose 15 pounds or 20 pounds to be at a healthy weight would not be a candidate for bariatric surgery. In fact, we follow fairly strict criteria to determine who is a candidate for bariatric surgery in the first place. In general, a person has to be about 100 pounds over their healthy or ideal body weight to be candidates for bariatric surgery. Another way to express that is to talk about body mass index, which is a number that we derive by putting the height and the weight of the person together. And the body mass index has to be at least 40 or greater. Sometimes a body mass index as low as 35 can make a person a candidate for bariatric surgery if they have already developed serious illnesses like type 2 diabetes, high blood pressure, or sleep apnea. So these are the general requirements to be a candidate for bariatric surgery. But then when we move into looking who would be a candidate for outpatient bariatric surgery, as I said, the vast majority of people will actually qualify. But then when we look in detail at the history of the person, there are certain criteria that we follow. They are actually criteria that we follow based on the guidelines of the MDS-AQIP, which is the body that accredits centers of excellence status to us. And currently, the MDS-AQIP stipulates that for a person to be a candidate for ambulatory or outpatient bariatric surgery, their age must be less than 65, right? So there is an age limit. Their age must be higher than 18, so there is an age limit from that point of view. And then we look at body mass index, right? Generally, a body mass index greater than 60 for a female, a body mass index greater than 55 for a male would not qualify them for outpatient bariatric surgery. So this would be in terms of the BMI or in terms of the weight of the person. Now, it's very important to understand that patients can come to us with body mass indices higher than that. And Kemal, you and I know very well that many patients, as they get through our program and they are educated, actually do end up losing some weight that would make them candidates then for ambulatory bariatric surgery. So that's from the weight point of view. But then there are certain other medical conditions that we look into to see if a person is a candidate. For instance, a person who has severe heart disease, they have advanced kidney disease, that they have bleeding disorders, a person who is on blood thinning medications, a person who has serious lung problems. Those patients, of course, would not be candidates for an outpatient surgery center. They have to be in a hospital where they may have to be admitted for several days after their surgery, and they may require input for different specialists for optimal outcome of their bariatric surgery. So in general, most patients who have morbid obesity are candidates, but there are obviously a category of patients that may not be candidates, and that is best determined after we meet the patients and find out about their medical history.
So, Dr. Irgau, I think there are a couple of different parts of the discussion, and when we say who's the candidate for the outpatient surgery center, I think we cannot ignore to mention that the surgeon piece is extremely important. So from the beginning, we were lucky enough, we were fortunate because we have the most specialized, most expertise in bariatric. And among our all the surgeons together, we are more than 10,000 bariatric surgeries in the last 10 years now, although you have been doing this more than 10 years. It's almost 22 now, if I'm not mistaken. Just in the last 3 years, there are more than 2,000 procedures that we have done. So we have to kind of mention that, of course, you have to have right expertise in the bariatric, because correct me if I'm wrong, but in many cases, surgeons also feel more safe in the hospital setting because they may need other people, but if the expertise is there, that's not the case. And also in the groups like us, we have 5 bariatric surgeons, and we always have another person available in case we don't want to have someone who doesn't have the expertise to help us when there's a problem, right? So we want someone who actually is as equivalently experienced as you are, who can actually come and help when there's a problem. So I think it is even safer because we also increase our screening process. So if I'm saying this, maybe, you know what, I'm just going to say it so that if I'm wrong, then they can correct it. I don't believe there are any other bariatric programs who have a daily case conference. Now, Dr. Irgau, you and I, we can certify this because you and I, we have been in so many other practices, so many other programs. In fact, you and our 2 other surgeons, they are the founder of the bariatric programs in the major hospitals in Delaware. But you and I, we travel a lot for this. And we know that this is not a daily discipline, and we are doing that in in American Surgery Center, and I do believe that that increases our safety for patients and for our surgeons, for our facility. So, Dr. Irgau, I would like to actually ask you when someone should be considering the bariatric surgery. Like a lot of people, they deal with obesity, and you have given us the criteria with the BMI and with the different illnesses, like the 35 BMI with diabetes. Now, if you can actually tell us, now, the reason I'm asking this is because we are also United Medical ACO in this setting, and with our primary cares, when we discuss why there were no follow-up on morbid obesity, sometimes they say that patient was not happy when they mentioned the bariatric surgery options, and there's this perception in the society with the surgery. And if you can explain when someone should be considering this surgery and why this may be the only viable option for those patients.
Yes, absolutely, Kemal. So, for most people, the most interesting thing about obesity is that its development is insidious. In other words, people slowly accumulate weight, 5 pounds, 10 pounds every year. And then suddenly they realize it's too much because it's impacting their daily life. The quality of life becomes worse, right? Whether it's inability to fit in a chair at a meeting, whether it's inability to take your child on a ride, whether it's inability to catch up or, for running after your grandchildren, suddenly you realize the weight has an impact on your life. That is the most obvious part for the patient. But when patients go to see their doctors, suddenly they realize that there are a number of medical problems that are listed that their doctor is coming up with, right? Whether it's diabetes, high blood pressure, sleep apnea, joint problems, infertility, all these others, right? Now, how we are waking up as doctors now is that we are understanding that the underlying problem of all these illnesses is the obesity itself. So we cannot ignore obesity and just talk about the diabetes, the high blood pressure, particularly when year after year, the measurement of the patient is going up, right? We look at the chart, the patient was 250 pounds last year, now they are 275. Next year, they are going to be 295. The year after are going to be 305. We cannot sit there and watch that go up, the patient's life be miserable, and not approach obesity as the main problem, as the disease. So first, we have to talk about it as a main health problem. Once we have determined that and gotten the focus of the patient in the right place for them to see as obesity, not necessarily as something that is affecting their daily life, as something they don't like about themselves, as something that is forcing them to abandon their clothing and buy other clothes, everything, but as something that affecting their health, then we can talk about solutions. Now, we want patients to try, we want patients to focus on their nutrition, to focus on their activity level. But what we know in reality, and what you and I, Kemal, know by being in this business now for so many years, is that once the weight gets to those levels, once a person is about 100 pounds over their ideal body weight, the chances are they will not be able to get rid of that weight with any other means but bariatric surgery. In other words, bariatric surgery is the most effective treatment we have now. But also we are living at a time not only when we have discovered that bariatric surgery is the only treatment, but we have made bariatric surgery the safest it's ever been, right? Major bariatric procedures we're doing as outpatients. Major bariatric surgeries are as safe as gallbladder surgery or hip replacement surgery. So we have an obligation as health care providers to present this education to our patients and let the idea mature in their head. Clearly, the vast majority of patients reject the idea of bariatric surgery when they first hear about it, saying it's not for me, I can do it in any other way. And that is okay. They need to be comfortable with that idea, but eventually they will come to terms with the fact that treatment is necessary, and the most important treatment right now is bariatric surgery.
Dr. Irgau, I think one of the really important part is when you look at the perception. I'm going to go back to, oh, they're going to remove the part of someone's stomach, or they're going to cut their stomach. So, well, that's kind of like maybe in a most not inaccurate way that you can say that, but the part what our stomach does and what actually makes us hungry, the role, it's not just like how much we eat, but how that is being communicated with our brain and
Yes,
what
absolutely.
part actually is causing that. And these patients, what they are struggling with, that actually is the extremely important part of the issue where I do see, these days, every time I see someone who may have morbid obesity, I can help and go up to them and then give them our information. And I may have, well, a couple times I got in trouble, but many of the times I was able to explain myself properly. These patients do need help. And, many people doesn't understand, and then we still fight with the perception, but just focusing on what it is that we are able to do from the type of the procedure, Dr. Gao, and very briefly, if you can actually tell us how we decide, and then I'm going to go to some of the patient experiences after that.
Absolutely. So we offer all types of procedures at CHRIAS. We are experienced with all types of procedures, from the very non-invasive procedure like a gastric balloon placement to fairly extensive procedures like the duodenal switch. The two more common procedures that we find that people choose to have are either the sleeve gastrectomy, right? This gastric sleeve, which is a procedure whereby part of the stomach is removed. And we at CHRIAS were actually the very first ones to perform that procedure in the state of Delaware. And we have done really thousands of them now among all the surgeons. So a sleeve gastrectomy involves removal of part of the stomach, so the stomach becomes narrow, pipe-like, or also banana shaped. So the surgery is focused on the stomach. I have to say that by far the vast majority of patients choose to have this procedure. The other procedure that comes after it in terms of common, that would be the sleeve. The other procedure that comes afterwards is the gastric bypass. With the gastric bypass, obviously, not only we are dividing the stomach, but we're doing something different also. We are rerouting the intestine. So the surgery involves changes on the stomach and changes on the intestine. So it is a more involved procedure. Obviously, there are implications long-term when we are rerouting the intestine. It's important for us to explain to patients about the implications in choosing the sleeve gastrectomy and gastric bypass. Now, there are a few situations, Kemal, where one procedure is way better for the patient than the other. But in general, most patients would be candidates for either procedure. And very often, patients will choose the less impactful procedure in terms of its long-term consequences, which is the sleeve gastrectomy, as opposed to the gastric bypass, which involves the rerouting of the intestine, and the rerouting of the intestine by itself has long-term implications. And in some cases, it may be the better procedure for patients, but we have to have that consultation for us to be able to decide on that.
I'm sorry, I'm going to ask you this
but,
in a way that just to simplify, and then I know that this will be different for each patient. Mm-hmm. But what I want to ask on behalf of like a potential candidate for this from the patient point. So let's say someone who's at age 42 with BMI 47. Okay. And they have sleep apnea, and their A1C is 7. So, and I'll actually just stop there, like that much. So, based on that, my understanding, and I'm not a surgeon, so I'm obviously I know a lot about the clinical side of it, but I'm not a licensed practitioner. So, but my understanding is in those types of cases, I would say that gastric sleeve would be the right choice for the patient. Would you agree?
I would in general, Kemal. So the first premise is obviously the worst option for the patient would be to do nothing, right? That would be the unacceptable, right? And then when we come to bariatric surgery, all those options are beneficial, but then we have to look at the impact long term, right? For instance, when we do the sleeve gastrectomy, the change is only on the stomach. When we do gastric bypass, for instance, by rerouting the intestine, we're opening up a set of potential problems long term, right? For instance, malnutrition. If a person is not really compliant with their vitamin intake because we have rerouted the intestine, they are at risk for malnutrition. Because we have rerouted the intestine and brought the intestine into a less natural position, there is a potential for that intestine to twist and cause bowel blockage. And about 10 to 15% of patients who have gastric bypass may end up having an operation to fix that. That is long term. Another potentially serious problem is the formation of ulcers at the connection between the little stomach and the intestine when we do gastric bypass. So those are potential problems that have to be balanced against the specific benefits of gastric bypass when we compare it to sleeve gastrectomy. The weight loss, Kemal, there is a perception that people who have gastric bypass lose more weight. Actually, the studies have shown that the weight loss is overall comparable when you take sleeve gastrectomy and gastric bypass. Now, in terms of improvement in diabetes, it is possible that the gastric bypass may have an edge in that the improvement of diabetes could happen soon after the surgery, even before they start losing weight. But even sleeve gastrectomy is very powerful in inducing improvement of type 2 diabetes. And that may happen as the person is losing weight, right? Now, there are certain situations, and we've talked about that in case conferences, where a person may not be a candidate for the sleeve gastrectomy. And that would be a situation in which a person who has some damage to their food pipe, something called Barrett's esophagus, for instance, that would preclude them from having the sleeve gastrectomy. But this is such a rare situation, Kemal, that it would not apply to the vast majority of patients. So the patient that you have presented as an example would do very well with the sleeve gastrectomy, but they could do well with the gastric bypass as well. But it is important for us to explain the implications long-term of each option. And although we are obviously holding a session right now, and our goal is to educate people, clearly what fits best the need of a particular patient is not decided in this setting. It's decided when that person comes for a one-to-one consultation with and establish a relationship with one of our surgeons. That would be the best time to decide that.
Absolutely. Now, Dr. Irgau, I'm going to actually talk about the cost of bariatric surgery in the surgery center, in American Surgery Center. Mm-hmm. Well, we do differentiate that because in the beginning we had some challenges. Interesting enough, the patient needed to pay more when it's not done in the most expensive hospital settings. Although, even though bigger percentages in the surgery center was still smaller than the hospital cost, but some people didn't have a good understanding of that. But also we did fix some of the issues from our certification standpoint. So I do want to go through that quickly, and then I do want to share some of our patient survey results. They're pretty interesting. You may think that I'm writing them, but I swear I'm not doing it. So they're real. I checked them. So here's the cost of the surgery at American Surgery Center for Bariatric. So once we know that all the criteria is met, like your weight loss attempts, comorbidity, like the other illnesses that you may have if the BMI is 35 to 39, your medications, this is mainly for the hypertension, visit with your primary care, and these needs to be obesity related, and also like some insurances may have some different requirements, but we take care of all those. The main thing are our patients. We expect them to just show up for the consult, and then from there, there will be an ownership from our side with a case manager, case care coordinator, and then they will make sure that you won't have to go through this if your insurance doesn't cover, or if you want to go for self-pay, we have self-pay options. But here are the insurances. Highmark, with the Blue Distinction Center. We are actually on our year 2. We got the Blue Distinction Center Plus, which means that there won't be any additional cost from any other places if you are getting the surgery done at American Surgery Center. And also we did the same thing for Aetna. They have a qualification called Aetna Institute of Quality, and then we obtained that last year. So for Highmark and Aetna, you don't have any additional cost other than your deductibles, and depends on your plan. You may have some. 2 Medicaid MCOs, MeriHealth and Highmark Health Options. We are contracted with them, and members do not have any cost, and then not only any cost, they don't have copays or co-insurance or deductible because they are part of Medicaid. And also, we have a contract with Cigna, and like any other facility that Cigna would cover, that's the same for American Surgery Center. Therefore, there are no additional costs for the patients. So we always mention the multidisciplinary approach, care coordinators, facility and practice nurses, nutritionists, psychologists, surgeons, primary care physician, cardiologists, pulmonary for the sleep apnea, and all these different specialties. We work together to make this happen for you. You may be working with one of these wonderful ladies. There are care managers, our nurses, and I apologize for not having Tuba's picture, but next time we'll have her. And you may be getting a call, or you may be getting a text message, you may be getting a portal message from them, because they will keep you on the right direction for getting your appointments, showing up for your appointments, your blood work, and all that. Now, let's actually talk about the surgery center and the patient satisfaction surveys. So I personally send surveys out for our patients through my office. Wonderful, and Wilson is helping me, and then I sign them personally. Each of them are signed in, like I do actually see them and sign them. And because I also do the daily case conferences, I know many of the patients by their name, and it's extremely satisfying to see someone who was in the case conference 2 months ago. Now I have to sign their survey letter. So, but this is our number here. So we are extremely proud of our 99.2%. This is 12 months. And I can tell you there's no other facility in the United States who have a similar result. Hospitals are usually running around 70 to 80%. Now, you're going to say, well, why, like how and why? Now, Dr. Irgau, you and I, we went through this. We changed the surgery center. We actually made something different than the typical surgery center, and especially in American Surgery Center, we actually took the staffing model out, and then we implemented our full-time, permanent, because we have some part-timers, but they are permanent part of the team. But we don't have much per diem nurses. We have our own nurses every day. Same nurses are there. So why this is important? Because this is giving that ownership and belonging to the facility. So our nurses are not feeling like, well, I'm going to work here one day, I'm going to work here another day. They work, this is their home. So because it's their home, the ownership is there from their side. And I think they provide an excellent service. Now, it is, when I used to get these survey results, I'm like, did one of the nurses write this, or did one of my assistants do that? So now here's what I actually see, and I share with our facility, and nice and friendly. I really felt comfortable. I would like to recognize here the names again. Okay, And this is not a copy paste. These are different patients. They're not copy pasting from one place to the other. So, and then this patient says, I work in customer service and finding such a great customer facing care and service is wonderful. So now, this is really interesting, Dr. Guy. I think I shared this with you. Patient says, I was very skeptical going in since I have never heard of American Surgery Center, but I quickly find out what a great group of professionals you have working with. Now, all these are coming to us in the last, this is from last week, Dr. Irgau.
Yeah, amazing.
Now, this is, to me, getting to this type of feedback and satisfaction, it's extremely pleasing. And I'm proud of being part of the team and running this team on behalf of our surgeons and working with you directly. So I do want to also remind our patients and future patients that we do telemedicine through Cerner IQ Health, but we also do other channels as well if it's not available for some cases. But even the initial consult can be done through telemedicine. We have, Dr. I didn't share this with you, but I have this new ring. It's Aura, I believe. So it's it actually keeps track of pretty much all the activities, the sleep, and you keep it on for the entire time. So when I see the telemedicine, I couldn't help but just mention this. So last week, if you remember, I did share the health application from iPhone, but this one takes it to a different level. It actually gives you the burning calories, resting, heart rate, and so much other information. Now, why this is important is because with the new world that we live in with the pandemic, we need access to certain things that we used to only be able to get it in our offices, such as patients' weight check, blood pressure, and others. So this type of device actually is more than just your Apple Health application, but it does talk to the main app. So I bought this. One of our managers here, Anna, I played tennis with her. She said, I need to get one of those. And I did. I listened and I did so. And it helps us to kind of be more active, but also try to get to know what's going through with your body. But in the setting like telemedicine, this would be an extremely useful information for us to be able to get from the patients. So finally, I do want to just remind everyone that we have our events on Fridays. This is I'm going to start calling these Bariatric Fridays. So we have our second and fourth Tuesdays, 6 p.m. CHRIAS weight loss seminars. If you want to know more in depth, like what the whole process is, you may want to just watch one of those. And then we have our United Medical ACO recent events. It's right before this event at 12 noon. And then Wednesday wellness webinar is second and fourth Wednesday, 7 p.m. The only thing that we didn't mention here is our support group. If you have a surgery from CHRIAS surgeons, there's a support group first Tuesday of every month. And then if we can add that here for next time. So that's going to be once a month. Done by mostly Dr. Gail Wynn does that for us. And then you can find all the other stuff from our different channels. Now, Dr. Irgau, I'll come back to you and ask you if you would like to add anything before we close.
Thank you, Kemal. Thank you. So thank you for sharing those wonderful feedbacks from the patients. It's really absolutely heartwarming and satisfying to see that. I can tell you that from my point of view, going into bariatric surgery was one of the best things that's ever happened to me, because as a physician, as a doctor, when you can help a patient really take care of many illnesses at once with one single treatment, with one single operation, it's really extremely satisfying. And then being part of this team also that has taken that care to a much higher level, providing a specialized center with professionals like the ones we have at the American Surgery Center. Really, I couldn't ask for more in terms of my own professional satisfaction. So it's really a win-win situation for all of us. Kemal, thank you.
I do believe that Bariatric Friday will help our patients to regain control of their lives. So I'm hoping that we can be part of their bariatric journey, and we'll be back here next week, same time. Dr. Irgau, thank you for joining me, and
thank you.
Bye-bye.